My name is Sean Muldoon. I'm the Chief Medical Officer and Senior Vice President for Kindred Healthcare's Hospital Division. We operate 121 long-term acute care hospitals in 46 states, and along with our skilled nursing facilities and acute rehabilitation services, we're the largest provider of acute care services in the United States. Kindred has joined with the Association for Clinical Documentation Improvement Specialists, which I'll refer to as ACDIS, to celebrate and recognize the work of these professionals. This video clip will introduce you to these professionals and show you the ways in which they can help you as physicians improve your patient care. In medicine, we live in a world of measurement and increasingly of accountability. We're continually asked, both as hospitals and physicians, to demonstrate that we understood a patient's conditions, that we selected interventions and treatments that were necessary and beneficial, that we monitored the response for things we wanted and things that we did not want, and that we got the best possible outcome at a reasonable cost. Often, the primary, or occasionally only place that this can be demonstrated is through the physician's documentation in the patient progress note. That's what makes the work of ACDIS and clinical documentation improvement specialists so important. So on behalf of ACDIS and Kindred, I hope that you'll continue to watch this video clip and gain some practical pointers and insight into clinical documentation.
Kindred as a company has been in great partnership and support of the Association of Clinical Documentation Improvement Specialists. We've worked very hard on their advisory board to help contribute to the field of growing the awareness of the CDI profession and what support skills and advantage this can bring to our physicians. The current system in the short-term and the long-term acute care hospitals is based on the medical severity DRG system, which has severity levels of different diagnosis groups. So for example, you can have the lowest, which is patient comes in with pneumonia and no other condition. You can have a second level that they come in with pneumonia and one other comorbid condition or complication. Or you can go to the top level of severity for that diagnosis. The patient comes in with pneumonia and what's known as an MCC. All of these carry different reimbursement rates and different estimates for length of stay. So it is important both for the physician and the hospital to get the most accurate so that we can care for our patients with the appropriate resources.
It's all depending on accurate documentation. If I documented the patient has malignant hypertension, accelerated hypertension, it will tell me why the patient stayed in the hospital extra days, and it will tell me why the patient has more frequent visits to the office. However, if I overlooked or failed to do so, then I could be viewed as being overutilizer, and that will be reflected in my quality profile.
If he documents accurately and he shows the severity of his patient's illness in his billing of his episodic visit to the hospital, and then the hospital can also pull the appropriate codes to reflect the right DRG, then it all appears in sync.
And certainly, if the documentation is not accurate, both the hospitals and the physicians could be denied payment.
Every diagnosis that a physician puts down on his medical record, if it is not clear enough, it does not pull the appropriate predicted mortality risk adjustment. So therefore, when they ask me, or they tell me, my patient is sicker, you're not getting that picture from the physician if his documentation isn't as specific and accurate as it can be. The CDI specialist is a trained professional, can be either a coder, can be a certified clinical documentation improvement specialist, can be a nurse, can be another person with background training that helps to bridge that gap between the health information management and the clinical staff and physician. So they have very specific skills to help query the physician for specificity or further clarification of what they're writing.
Queries are questions asked to treating physician to clarify and obtain additional diagnoses or obtain more specificity on what's written in the chart so we can achieve accurate coding. Questions and queries can be asked in several conditions. For example, if a physician writes congestive heart failure, a query would be generated to ask him what type. Is it acute, chronic, is it systolic or diastolic? A principal diagnosis ends up being as a symptom, syncope. A query will be generated asking, what is the cause of the syncope? Is it renal failure? Is it cardiac arrhythmia? That will actually reflect differently than having the diagnosis being a symptom alone. But more importantly, queries now are being utilized in the present on admission conditions. If a condition as a secondary diagnosis is present in the chart, if the physician write down it's present on admission, it's a comorbid condition. If it is not present on admission, it will be counted as hospital acquired and could be classified as complication.
In my work with the ACDIS board, we've worked with many hospitals across the country, and we absolutely see a difference when we have CDI specialists and physician advisors who help our physicians, and when we have a CDI program within an organization. It not only reflects better quality rates when we look at the interpretation of quality in the public profiles, but we're seeing accurate and appropriate reimbursement that comes back for care.
We are seeing, and I can speak from experience, that clinical documentation has improved physician profiles in the programs and in the hospital that utilize such programs.
We found that before we implemented a CDI program, we were not looking as good in risk-adjusted outcomes, and that was felt to be because the documentation was not as accurate. After we implemented a CDI program, we looked several times better than in percentages in the risk-adjusted mortality. So that's the difference between being a one-star hospital and being a five-star hospital, which we all want to be.
We have it actually tested again and again. The hospitals that have clinical documentation program have better profiles.
The care of the physicians can be the same, but the way it's being interpreted now through those numerical ICD-9 and upcoming more specific ICD-10 codes is they're being viewed and interpreted as their patients are sicker.
You may be a good doctor and skilled physician. However, if you fail to document, you will be surprised to see your quality profile not ranked as high.
We have very smart consumers now who are choosing where they go for care when they can. Either their insurance companies are going for the most quality providers, or they're getting online now and seeking the hospitals and physicians who have the best quality of care outcomes. And those outcomes are taken from the data from the hospital and the physician's documentation.